The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to the first Canadian Frailty Network Hot Topics webinar titled Influenza Vaccination, a Shot Against Frailty for Older Adults. We're very excited to launch this news series, which will provide evidence-based information on key and important issues regarding older adults living with frailty. I'd like to begin by thanking everyone who has joined us today, and also our three expert presenters, and a special note of thanks to our presenting partner, Sanofi Pasteur. Before we get going, I'm just going to cover off a few housekeeping items. First off, my name is Peter Aitken. I'm a manager of partnerships for CFN, and I'll be your host for today's session. Next, for all participants, I just want to let you know you can submit questions at any time throughout the webinar, even as the speakers are presenting. For our part, we'll try our best to answer as many questions as possible today. Next, here is our agenda. We're going to first hear from Stefan Gravenstein, then Melissa Andrew, and then finish up with Richard Badek. Each presenter will speak for about 20 minutes, followed by about 5 minutes of Q&A. Once all the presentations are completed, we're going to have an open Q&A with the panel for about 15 minutes or so, depending on where our time is at. Now, as I mentioned, this session on influenza and vaccination is our first Hot Topics webinar. We have more sessions and other key issues that are in the pipeline, which will be announced soon. But I just wanted to note for everyone in the line today, from different stakeholder groups, organizations who might have expertise to share, we'd like to hear from you to see if there are opportunities to collaborate in future sessions, perhaps in topics like nutrition, mobility, legal, financial, and advanced care planning, to have further sessions just like this one. So on the screen, you'll note there's contact information for our Associate Scientific Director, Perry Kim, via the email on screen. As a final note, we have two webinars also scheduled this fall, which focus on CFN-funded research, which are listed on the screen. November 7th, quickly, it's on the topic of appropriate medication in geriatrics and long-term care. November 21st at noon, we'll take a look, a national perspective on the state of end-of-life care in Canada. We really hope you'll join us for these sessions. You can register on our website at any time and also use the link which is on screen. So we have a busy schedule, so without further ado, I'm delighted to welcome Stefan Gravenstein as our first presenter. Stefan's, as you can see on the screen, is a professor of medicine and professor of health services, policy, and practice for the Schools of Medicine and Public Health at Brown University. He's also clinical director at Health Centric Advisors, Medicare's quality improvement organization for New England. And he's well known for his expertise and long-standing interest in immunity, inflammation, and aging, especially in the context of vaccines and the long-term care settings. And he also has a specific interest in quality improvement in healthcare and the culture of care and antimicrobial stewardship and how to improve care across the entire care continuum. So without further ado, Dr. Gravenstein, the floor is yours. Just a quick reminder to please set yourself as a presenter to control your slides.
I'm going to see if I can swap screens here. Okay. Thank you. Thank you for inviting me to participate in this. You've already heard who I am. So I'd like to do some quick disclosures. I have conflicts. I'm funded by industry for vaccine research. I also get honorarium and consulting fees for this, and I also have federally supported grants, also mostly around vaccines and aging. So three general areas I'm going to cover is influenza vaccine and who cares. I get a lot of this from my patients to say, well, you know, I don't get sick, or I get sick and the vaccine doesn't work, or I get sick from the vaccine, and so why would I care? And then I'll do a what and how following that. So let's start off with who cares. First of all, I think it's useful to remind us that flu isn't just a cold. in frail elderly, and often isn't given its due for the misery and debility it creates. It actually causes a whole lot more than just a cold. Most of the time when we get flu, since all of us who are listening have clearly recovered, it seems like it must not have been that big a deal because here we are. But the thing is I think it's not obvious to a lot of folks that it creates debility and effects that you may not associate with flu. So the reason we don't know is because we think of flu as something where we've overcome it and here we are, we're just fine. And maybe it was just a cold and no biggie, or no one has told us it does all these other things that we would reasonably not want, you know, sort of like the argument you use for, say, quitting smoking or eating more healthy. So what we can do, and this is actually pretty simple. So the backdrop for this, to try to understand that it does something more than just give you a cold-like symptoms, is to recognize the context of what happens when we get older and what happens as we become frail. So in general, frailty and age together have a joint outcome of an increased likelihood for infection, like pneumonia. And the more severe infections also can cause us to be hospitalized. A second thing is the vaccines we use to prevent pneumonia, including flu vaccine and the pneumococcal vaccines, they don't work as well in older people, and they don't work as well in people who are frail. So we need better vaccines to overcome this declining response, this thing we call immune senescence, the part of aging. And when we do respond, the response isn't just not as big, it doesn't last as long. When we get older and we get sick, we recover more slowly. So if you get the flu or you get pneumonia, the days until you're back to your usual activities is typically more. And to give you an example, in 20, 30, 40, 50-year-olds, when we get a case of the flu, usually within a week or two, we're back on our feet doing the stuff we were doing before. But if you're 80, that same recovery may take months. And then finally, as we get older, we have different symptoms. So when we get infection, this is any kind of infection, and our body starts to fight it. This is the immune response. Because the molecules our body makes to fight that response. So I'll use an example of a name of one of these molecules, cytokines. We don't make as many cytokines, and that less cytokines means we have less of the white blood cells that are activated to fight the infection. But the cytokines themselves, part of being sick, produce some of the symptoms we get when we're sick. So, for example, if you get muscle aches from flu, the term for that would be myalgias. The muscle aches in old people aren't as severe in young people, even if you have just as much virus. And a second feature of that, when you're feeling grungy from the flu, muscle aches and fever and headaches and sort of the overall malaise and so forth, this isn't because there's virus that gets into your muscles and into your head. It's the cytokines that the virus is causing in the immune response that makes us feel run down and lack of appetite and muscle aches. So when we're older, we make fewer of these cytokines, so we don't look or feel quite as sick. And so when we get sick with the flu, we're not quite as likely to go see the doc and say, hey, I'm feeling awful, because you may not feel awful. You might just feel a little run down, even if it's going to be ultimately something that puts you in the hospital or kills you. So as we get older, because of this immune senescence, we have a low response with age. That means when you get a flu vaccine, you don't respond quite as well, or you get a shingles vaccine, you don't respond as well, or a pneumococcal vaccine, essentially any vaccine, you don't get quite the same protection as when you're younger. And because you have less of immune response, you have less fever and less muscle aches, less malaise, not quite as much anorexia. Your development of these symptoms is slower because the kick up of the cytokines is slower. And the resolution of the symptoms is slower because the return of the cytokines back to a baseline level takes longer. So you have milder symptoms that last longer, and what might have lasted just a week or two in a young person might last for months in an old person. And then the outcome of those cytokines is that you can get functional loss, but also vascular outcomes, which I'll talk about next. So immune senescence changes how sick we look. It changes what happens when we get sick. When we get infected, age changes our appetite, energy, functional independence, and risk for disability. So this business about the cytokines is something that occurs with infection, and infection drives part of this response, which we call inflammation. And that inflammatory response generates these vascular outcomes. And I'm going to talk about those now. And I'll talk about it in this particular study first. What I want you to see in this study is this is where they were looking at people who had respiratory tract infections and bladder infections, UTIs, urinary tract infections. And in the red box, you can see that you have some 20,000 people here that are represented with a systemic respiratory tract infection. And UTI, bladder infections, 10,000 people in the sample. And they've looked at them in Medicare claims in the 2 weeks following the infection, and in the first 2 weeks following a respiratory tract infection, the risk, 3.8, of a roughly 4-fold greater risk of having a first ever heart attack was in the first 2 weeks. And if you follow it out to the right, in the first month, 2-fold greater risk, and in the third month, still a 50%, 40% greater risk of having a first ever heart attack. Now the box is supposed to tell you a second thing, and the UTI, is you have an elevated risk following a non-respiratory tract infection, in this case a bladder infection, that's elevated 60% in the first couple of weeks, and the tail goes out to 3 months. Still, even in the third month, there's a 20% increased risk for having a first ever heart attack. The bottom part of this is first ever stroke. And again, following respiratory tract infections, you have a 2 to 3-fold increased risk of respiratory tract infection with a tail that lasts out of 3 to 3 months. And 2 to 3-fold increase of bladder infections, also, again, standing out for a few months after that initial infection. So the point behind the slide is when you have an infection, and in this case, respiratory tract infection or bladder infection, you get inflammation that increases the risk for clotting. And if that clot happens in your heart, you get a first ever heart attack, or in your brain, you get a first ever stroke. And following these two types of infections, you have a risk with the big tail that goes long after the actual infection took place. So this is now specific to pneumonia, bad enough to hospitalize you. So we're not talking about specifically flu, but pneumonia more in general. A quarter of people who are hospitalized with pneumonia develop a major acute cardiac complication during their stay, and over half of those are likely to die. In a separate prospective study published in 2017, 1,200 people admitted with pneumonia, a third of them had a cardiovascular event, and of that, there was a 3-fold greater risk of mortality in the month that followed. So a third type of inflammation, in this case, it's shingles. So I've told you bladder infection, I've told you respiratory tract infection, I've told you specifically pneumonia, and now shingles. So when you get shingles, you probably know that this is a virus that sits in your dorsal root ganglion next to your spine. And when you are severely stressed or get chemotherapy or are on heavy dose immunosuppressants, you can have an outbreak of shingles, a rash that can be painful. Now, following shingles, it turns out you have a 50, 60% overall increased risk of heart attack. That's greater as you get older. And you have a greater risk for stroke. So again, the point of making an increased risk for inflammation leading to a heart attack or stroke. So in that, under Erskine, you can see stroke, the first line, is that elevated risk is 2 to 4-fold, and with a tail that lasts out for 3 months, just as I showed you in that first table from Smith with systemic respiratory tract infections and bladder infections. So when I try to explain this to my medical residents, these are physicians in training, one of the ways we talk about this is inflammation. And when we measure inflammation, we might measure cytokines. On the left-hand side here, you can see IL-1, interleukin-1, and interleukin-6, or C-reactive protein, or serum amyloid A, or fibrinogen activation. Those are all measures of inflammation. When we are born, when these measures are low, our likelihood of having a clot, like one that can show up in our legs or brain or heart, is pretty low. And as we get inflammation, our propensity to clot, the likelihood of developing that clot, goes up. And just aging can kick up that risk just a little bit. You can see the thrombometer is kicked up a little bit, and those markers all go up. You add to that underlying diseases like obesity or diabetes or arthritis, emphysema, and you can see the thrombometer kicks up some more, and those markers kick up higher. And your risk for having a clot outcome, stroke or heart attack, or from cytokines, delirium, and so forth, also goes up. You layer on top of that an infection, and at that moment, if you happen to be old and have risk conditions and have infection, your thrombometer tops out, and your risk for having that heart attack or stroke is at a maximum. So when we talk about inflammation and aging, we're talking about inflammatory events that layer on top of other risk factors such as age and comorbid conditions. Because of immune senescence, the effectiveness of these regular vaccines is somewhat less. And in this slide, you can see the effectiveness of the vaccine of preventing influenza-like illness is 30 to 50% less. That's the blue line compared to the gray line in people that are over the age of 65. So the blue line is people over the age of 65 have less vaccine effectiveness than the younger ones. So for this reason, you'd want to have a better vaccine. But having said that, any vaccine is better than no vaccine. So this is a paper on any flu vaccine done by McIntyre, published 2 years ago. And what you should see here is the effectiveness of preventing a heart attack is as good from flu vaccine as it is from quitting smoking, taking medications for cholesterol, taking blood pressure medications. So you get a 15 to 45% reduction in your risk for having a heart attack from getting a flu vaccine, which is a pretty good deal. The only thing that's cheaper than getting a flu vaccine is quitting smoking. But if you get both, you get added effect. So we need better vaccines that are specific to older adults to get that effect even bigger. So for pneumonia vaccines out there is pneumococcal polysaccharide vaccine. The brand name for that is Pneumovax. And the conjugated pneumococcal vaccine, Prevnar. And for our older adults in the US, we recommend that they get them both. For flu vaccines, we have 2 special vaccines for older adults. The high-dose influenza vaccine, this is Fluzone Highdose is the brand name, and the adjuvanted influenza vaccine, Fluad. And then for shingles, there's also now a new vaccine out there that's more effective against shingles. And for adults over the age of 65 in the US now, Shingrix is the recombinant vaccine, that's the preferred vaccine. So let's talk about particularly frail older folks. And in this case, I'm talking about folks who live in long-term care facilities. And one of the things that when we get the newspaper articles that says, oh my God, we have a vaccine that's not very effective, it's not a good match. So when we get those announcements, it's usually the public health authority that is saying that somehow the vaccine, what's in the vaccine, doesn't resemble what is circulating in the community very well. And the question is when that happens, and they say the vaccine isn't working well, do you still get benefit? So in this next study, I'm showing you that even with a poorly matched vaccine, you can get benefit. So this is a study we published back in 2010, and we were looking at people living in nursing homes. And in this study, we were visiting them every 2 weeks, twice a week, completely different. We were visiting these people coming to the bedside looking for any clinical signs of infection, a runny nose, or change in behavior like wandering or calling out that was new or something like that. And if they had anything new, we would collect a nasal swab and test them for flu. And in testing them for flu, we then also would start following them every day for 3 weeks to see how their symptoms went over time. So this graph is showing percent of subjects who had a fever, but it's only showing the people who tested positive for flu. So these are people who were infected with influenza based on a laboratory test and their daily temperature following that. So the first thing you should see is that the likelihood of having a high fever. So often we think of fever being 38 degrees or 101 or 102 Fahrenheit. And here you can see fewer than half, even if they got no vaccine, ever generated much of a fever over 37.2. So if you're using fever as a threshold criterion for saying whether they have flu or not, you'll miss the diagnosis half the time. Second thing that you should see here, and this is in the green and the pink lines, those are people who got vaccine as opposed to the blue line. They did not get a vaccine. Whether they got a good match vaccine or a bad match vaccine, in both cases they had less fever. Now, the third thing that you should see is that when they had an elevation in temperature with both good match and bad match vaccines, in both cases, the resolution of fever was much sooner, up to a couple of weeks sooner compared to those in the unvaccinated group. So what you should take away from this slide is with a good match vaccine as well as with a bad match vaccine, you get attenuation of symptoms. What you cannot tell from this slide easily is it looks like the good match vaccine, that middle line, may not be working as well as the bad match vaccine. What you can't tell from the slide is that the attack rate in the people who got the good match vaccine was much less. So in the pink and the blue lines, the bad match and no vaccine, the attack rate was about the same, just the people who were in the pink line didn't get nearly as sick. In the green line, far fewer people got sick. So the few people who did get sick look like they did a little worse, and it might be that any vaccine might not have protected them. So let's step back into the long-term care setting and vaccination and cardiovascular, in fact. And so first, I'd like to remind you that even when there's a bad match vaccine, you still get benefit, even in ways that don't sound at all like influenza, and cardiovascular outcomes is part of what we're going to talk about. So there's two new vaccines that are out there that are specific for the 65 and older. One is high-dose influenza vaccine, and that vaccine has 4 times more of the flu stuff in it than regular vaccines. That means that when older people get the vaccine, they produce more antibody. And in some of those studies, they've shown that the amount of antibody these older individuals that get the high-dose vaccine produce is comparable to what younger people get with a regular vaccine. So it boosts up the immunity quite a bit. And when you do these formal, what they call randomized control trials, that the risk reduction you get relative to regular vaccine in old people is 20 to 24% fewer laboratory confirmed cases of clinical influenza. Also, you get a reduced risk for hospitalization, 6 to 30%, depending on exactly how you measure it, from outpatient and nursing home settings. And it's recognized by the public health authorities, both in the US and Canada, as being superior over regular vaccines in older adults. For the adjuvanted influenza vaccine, the adjuvant here is an added molecule called squalene or MF59, and it's mixed in with the regular dose of influenza antigen. When you give this to older people, there's now several studies that show you produce more antibody than the regular vaccine. We are still awaiting higher quality evidence for its clinical benefit. So when you take the retrospective, the lower quality evidence, it appears that the effect size might be similar to what you get with high dose, but the quality of the current evidence isn't there yet in a formal randomized control trial to say that it is as good or clinically better. So our assumption would be that it probably is better than regular vaccine, but we're awaiting the data. We did 2 studies with high-dose vaccine in nursing home elderly that were published last year. 2012-13 was one study where we had an AH3 in 2 year. It was a small study, but it was a very busy year with flu. And then the second one says 2012, 2014. It should say 2013, 2014. So it was the second season. And that was predominantly an AH1 in 1 year. And it's the kind of flu strain that we typically think is not as important for older folks. So I'm going to show you a slide here that speaks to a couple of things. So the 2 places that are highlighted in yellow is our feasibility study, the small study, and the full study in the 2012-13 and the 13-14 season. And the first thing I want you to notice is in the 12-13 season, where the red arrows point, we had an AH3 predominant season, meaning the main circulating flu virus was an influenza A H3N2 virus. The green line that the arrows are pointing to is the hospitalization rates in the US for people aged 65 and over. And what you should see is the area under the curve is a lot for these three H3N2 seasons. That tells you about the total number of people hospitalized. And the 65 and older make up most of the people who are hospitalized. The other age groups, which are all the other lines, don't make up a lot of the hospitalizations. So in an H3N2 seasons, we always get more hospitalizations, and this last season was no exception, the 2017-2018 season. And the coming season, we don't know yet what it's going to be, but if it's an H3N2 season, again, we'd expect lots of excess hospitalization like this. Now, in our two studies, the second year was an H1N1 season, and when you look at the other H1N1 season, influenza B, you can see there's much less hospitalization. So we had a relatively mild season for the full study, a pretty severe season for the small study. So these are the two seasons where we studied, and you can see that difference in hospitalization rate, more than 4 times more hospitalization in the 65 plus. So this is the outcome of the small study. In this small study, we had about 3,000 people who were in our analytic sample, and we followed them for the whole flu season. And this graph shows at the beginning of the flu season, this is starting in November 1, following them for 6 months. At the end of 100 days, you can see that there's a 30% difference in hospitalization. So the top line is who's left that hasn't been hospitalized in the a group that got the high-dose vaccine, and the bottom line is in the group that got standard dose vaccine. So about 30% fewer people were hospitalized for any reason with high-dose vaccine through May. For the large study, we had about 8% fewer hospitalized. So when I go back to the big study, this was a very severe season. So the opportunity for reducing hospitalization was huge. Remember, that was this season with lots of area under the curve on the left. For the big study, it was a relatively mild season, and so the opportunity to reduce hospitalizations was less. But we still had about 8% fewer hospitalizations for any reason with the high-dose vaccine through May in an H1N1 predominant season. When you calculate for that mild season, how many people in the nursing home had to be offered a vaccine in order to stay out of the hospital all season for any reason? And the calculation on that, on our what we call our fee-for-service sample, is about 69. So to keep one person out of the hospital all flu season, 69 high-dose vaccines instead of a regular dose vaccine had to be given. Now, when we do a cost-benefit analysis in the US, that comes out to a number that is something bigger than $500 per vaccine offered after you pay for the vaccine, the difference in the vaccine cost and giving the vaccine. So it actually saves the government money for high-dose vaccine in this particular sample. When we looked at our larger sample of 52,000 people in the study, that number was calculated out to 81. So when somebody says, how many shots do I have to give to keep somebody out of the hospital? I say probably some number less than 100, depending on how bad the flu season is and the given profile of how effective the vaccine is. So to put this another way, we prevented hospitalizations. That bottom pair of bars, red and blue, red is high dose, blue is standard dose. This is the number of people being hospitalized, and what you should see here is in the high dose, about 3,500 people got hospitalized, and in the regular dose, about 3,800, so a difference of almost 300. So the delta there is 279 to be precise. This is the unadjusted number of 7.4%. The adjusted number comes out to 8.5%, which is why I gave you 8% before. So being hospitalized for any reason, about around 8% less risk of being hospitalized. But when we look at this, remember this is a flu vaccine, so what you'd expect it to do is prevent respiratory hospitalization. So the second set of bars in there is where they were hospitalized for a respiratory reason. And you can see that the delta there, which is 92, so about 100 people, fewer people were hospitalized for a respiratory diagnosis, which is only a third of that difference of 300. The other 2/3 were hospitalized for a cardiac diagnosis. And the example I use here, that's the third set of bars, heart attack, heart failure, or atrial fibrillation. So about 200, 2/3 of the difference. and hospitalization reduction could be explained by cardiovascular causes, and 1/3 by respiratory. And of that group of respiratory causes, of that 92, 61 or 2/3 were because of pneumonia. So if we were only counting respiratory hospitalizations or pneumonia, we would have missed a lot of the benefit, relative benefit we got from giving them the high-dose vaccine. So I'm going to show you a little video here because this is a parody about what I have to, when I talk to my colleagues about, how hard it is to get the diagnosis of flu out of somebody, but this is done now using alcohol. So that's, they had a heart attack. I said they just had the flu. And to get my colleagues to get that is interesting. So when I'm in the emergency room and somebody presents with an MI, I'm asking about, have they had an infection lately, runny nose, other kinds of things, what else is going on that made them present with a heart attack that day or a stroke. So, so when I'm doing the pitch to my patients to get them to take the vaccine, I'm thinking about, this isn't just about the cold, preventing a cold. It's actually preventing much bigger things like heart attacks, strokes, and so forth. So we have the similar challenge for our healthcare workers, how we can get our healthcare workers to keep from giving disease to their patients or getting their disease from patients to give to others. So we're preventing this contagious spread, occupational exposure, and exposure outside of work. For our nursing home residents, again, another pitch. Someone say, well, I'm ready to die. And I said, the thing is just because you have a heart attack or a stroke doesn't mean it kills you. It may just maim you. So suddenly there's things that you enjoy doing that you can't do anymore. It's cheaper than getting treated for it, and you don't have to get sick, and you can avoid hospitalizations. All good things to prevent. So it's a different pitch, slightly depending on which audience you go to. And if you're out there advocating for getting flu shots, you can help frame the pitch for the audience you have in mind. When we do it in a healthcare settings, we also say, you need to do this in a systematic way, whether it's in the office or in the nursing home. You make it a standing order, so it's just part of what you do. And you offer it in a way that it's an expectation, not an option. So you've got to give a strong recommendation. So I'm giving you your scheduled flu vaccine, as opposed to would you like your influenza vaccine this year? And you say, I believe in this. I get it. I give it to everybody in my family and everybody that works with me. We do this because this is part of good care. And why would you be any different? You ought to have this. You counter the thing where they think maybe they get flu from it. When they tell me that, I said, that's probably a good thing. It means your immune system's responding to it because you can't get flu from the flu shot. But if you have a good response, which means you'll have good protection. And then the argument about preventing heart attacks. So those are all part of this thing. So the overall summary here is aging and frailty increases the risk for infectious complications. Flu and other infections are more than just infections in older adults. The impact on heart and brain as we age are important, and they're an uncounted consequence. So vaccinate, good match or not, and think about if you have it available, the more immunogenic vaccines can offer you better protection. So there's some resources here. I'm happy for these slides to be shared. You can click, if you get them in a PDF, you can click on the links and get more information. So I'm open for questions unless you're going to hold them for later.
Stefan, thanks so very much for that terrific presentation. A lot of really, really interesting information there, and I think particularly a very powerful message about the comparison you provided of sort of the proactive and positive related health impacts related to vaccination. I think what we'll do in the interest of time, we'll move straight on to Melissa, and then we'll address some of the questions when we do the open session. So moving on, it's a great pleasure to have Melissa Andrew as a presenter today and share her significant expertise at this webinar. Excuse me. As you see on the slide, she's an associate professor of medicine at Dalhousie and a consultant in geriatric medicine at QE2 Health Sciences in Halifax. She's also the principal investigator of the Public Health Agency of Canada, CIHR's Serious Outcomes Surveillance Network, where she studies exactly our topic today on how frailty impacts vaccine effectiveness and other related topics. And we're also very proud of the fact that she is a CFN-funded researcher on numerous studies. So, Melissa, the floor is yours, and a second reminder, just set yourself as the presenter, and off we go.
Great. Thank you for the opportunity to present today. I think I'm backwards on my screen, so I'm just trying to fix that. Where did it go? Sorry about this. I can see I have two screens. That's my problem. Somehow the presenter mode is not going up on it. Do you have any ideas of how to make this work, Peter? Sorry, everybody. I had this working yesterday.
No problem.
Like,
Matt, are you on the line where you might be able to help out a bit?
Hey, Peter. Hey, Melissa. So I'll just put your slides up on my end, and you can just read on the screen there.
That's perfect.
Great fix. Thanks, guys.
Sorry for that. Okay. So yes, thank you so much, everybody. And what I was going to try to share with you today is some of our experience here in Canada. So I really enjoyed Stefan's presentation because it's really well aligned with exactly what we're seeing here too. Okay, so I also have disclosures with grant funding to do these and other related studies from various industry partners, as well as partners like the Canadian Frailty Network and the CIHR. So the next slide, I wanted to share with you 3 key points. So I'll tell these to you up front, and then we'll just work our way through. So the first point is that frail older adults are at higher risk for influenza and for its complications, exactly what we heard earlier, but the vaccine effectiveness is lower. And what we're understanding now from studies that we've been doing on vaccine effectiveness in the real world settings is that if we don't consider frailty, we tend to underestimate vaccine effectiveness, which really impacts on our message around the importance of vaccines in this population. The second thing is that the burden of influenza is usually thought of over short-term time horizons. So we usually, as again, Stefan mentioned, we think of it as being a thing that you get over within a couple of weeks and it's no big deal. But in fact, especially with our older population, we need to think about broadening that time horizon to include the longer-term outcomes, such as persistent functional declines and worsening frailty, as really part of what we're trying to prevent when we prevent the flu. And then the third thing is that older adults may not present with the typical type of symptoms of influenza, and this has implications for our surveillance activities and also for clinical care. So you might have wondered when you saw this webinar topic, so what does frailty have to do with influenza? And so we're putting the puzzle together for you here today. So next slide. On our first key point, I'll share with you some information about our hospital surveillance network here in Canada, which is called the Serious Outcomes Surveillance Network. It's part of the Canadian Immunization Research Network. So we've been doing active surveillance. Next slide here, where it's the map. Active surveillance for influenza at many sites across Canada over the last number of years. And in fact, this has continued on into the current season as well. And it has varied in the sites over time according to what funding we have. It's quite large, and it's at its peak it represented about a third of inpatient beds in Canada, so it's quite significant. Next slide. So the idea of what we call active surveillance is that we have to go out looking for people being admitted with the flu. We don't want to wait for a test to come back positive to show that they had the flu, because in fact, as we've heard, if you don't test for the flu, you may well miss it in someone who has come in with a stroke or a heart attack or an exacerbation of another illness. So we have a very broad definition of who we go out looking for influenza in. And then we test people who are enrolled in the network then. And then the people who come back having the flu on this PCR-based test are called cases, and then the people who don't are still enrolled as control, so we can compare their outcomes. So next slide. And there is a way to calculate the vaccine effectiveness using this methodology, and really we don't have to be burdened with the details, but it's just looking at how many people who had the flu were vaccinated versus not vaccinated. And then we can look at the vaccine effectiveness according to different things like their age group, their chronic conditions that they might have, or high risk groups. And then we can also look at frailty. And one of the unique things about our network is that we've been interested from the beginning in outcomes and health measures that are important for older adults. So we've had a measure of frailty, and also we think about function in activities of daily living, and also things like mobility. So these are really important outcomes for older adults. So this is just an example of the types of things we include in our measure of frailty. So we use a broad definition of frailty that's looking at deficit accumulation across multiple domains. So we think about their cognition, their mood, sensory impairments, mobility, difficulties, falls, nutrition, weight loss, function in various activities of their daily living, skin integrity with breakdown or ulcers, continence, bowel and bladder. And then we look at a number of chronic medical conditions as well. So it's really quite a broad measure of frailty. So next slide. So just to share with you a couple of things. So first of all, we noticed this interesting trend, and this is just one season, 2011-12, but the trend occurs in other seasons, in all the seasons really, that as people get older, they're more likely to have been vaccinated. So that's just the green piece of the pie in the top row there, is showing that the oldest people are more likely to be vaccinated, but still not ideal in terms of hitting the targets of 70 or more percent, or 80% even, that we'd like to see. This particular season was interesting in that there was 4 different circulating strains. So you've heard about each flu season is different, and some of them have influenza A, H3, and some of them have a H1. And these are just different types of influenza that tend to hit different age groups. And we just noticed that there are differences across those groups. We also noticed, of course, that the mortality is quite significant in the near term, up to 15% in the oldest group there. But interestingly, and this is, of course, what you'd see in other aspects of the work of the Frailty Network, is that most likely in relation to people's goals of care, ICU admissions are actually lower in the oldest people. When we think about frailty, which is the next slide, it's also interesting to note that the most frail people tend to be the ones who have the flu vaccine. This is in his population samples. And that's important to us because that means that if we're not thinking about that fact, it's sort of the opposite of what we think about it in a lot of vaccine studies, that the healthiest people are the ones who are doing these important health behaviors. But here, where there's been messaging for many years about the importance of getting a flu vaccine when one has chronic conditions, that has taken up in the population such that the frailer people are more likely to get it. Also, certainly it's more likely to be provided in nursing homes where a lot of our patients are coming from. So we'll just keep that in mind. So to the next slide. So this comes from a paper that we published. You'll see the table on the next slide there from that same season. And we found that overall, the unadjusted vaccine effectiveness, meaning before you take into account the various things like their age and their exposures and their frailty, was about 45% in the older adults. It's interesting that as a quirk of that season, the vaccine effectiveness in older people appeared to be higher than in younger people. Often it's not that way though. But when we adjusted for the various confounding variables, we noticed that in fact the vaccine effectiveness goes up quite a lot. And if you press the next slide there, even if you adjust for only frailty, it very closely approximates the final full model. So our take home from that is that frailty is the most important thing to be thinking about when you're looking at vaccine effectiveness in older adults. The next slide just shows this as well. So this is demonstrating the vaccine effectiveness from the left to the right is the non-frail people, the pre-frail people are in red, the frail people are in green, and the most frail, which is a small group in that particular year, are in the purple. And so often we hear this story that, well, why should older adults bother getting the flu vaccine because it doesn't work anyway? It's not as effective in older people as it would be in younger people. And so what we are finding is that counter to that, in fact, particularly in the fit and the pre-frail people, and to some degree the frail, but not the most extremely frail, the vaccine effectiveness is actually quite good. So that's an important message for the population that you're trying to target the healthy aging messaging towards, to say you want to stay healthy, you want to stay in this non-frail category. You know, one way to do that is to get your flu vaccine. And it is relevant if you push the next slide button, or it's just a little box there. Only about 24% of the population would be considered frail on these measures usually. So there's a big target population, about 75% out there for whom this is very relevant. So we shouldn't give up on even existing flu vaccines to say that they're not working, because in fact, if you account for frailty, they can be actually quite effective. All right, next slide. And this is really just counter to what we usually think of as this healthy user bias. We've identified this frailty bias, which is probably a type of indication bias in technical terms, just like if you think about who's getting the flu vaccine, and if they're also way more likely to have adverse consequences from the flu, or more likely to get the flu, then it may look like the vaccine isn't working as well, even though it's actually doing quite a good job. And you would tend to underestimate vaccine effectiveness if you don't take this into account. All right, so next slide. So that's the first key point done. The second key point now is that we're talking about the time horizons, and especially a persistent functional decline, or another way we another thing we call this is catastrophic disability. So next slide. We know in geriatrics, in the literature, that functional declines are actually very common when older people are in hospital. So this is just a slide from a classic paper showing how you take a cohort of people admitted to hospital, and at least a third of them will end up worse off in terms of their daily function than they were when they came in. And this is something that not everybody has top of mind when they're thinking about going into the hospital. So we'd like to keep people out of hospital as much as possible, especially when something is preventable, as with influenza. Okay, next slide. So from our SOS network, we have found that a good 15 or more % of older adults have what we have called persistent catastrophic disability, meaning that they've had a loss in the ability to do more than 2 basic activities of daily living following an admission with an illness such as the flu. So that would have a real impact on people's life. You imagine they came in able to get dressed, go to the bathroom, ambulate around their house, and they leave needing help with dressing and going to the bathroom. That's a huge impact on their life, their family and loved ones, and also on the amount of care that they would need going forward. And maybe the type of thing that tips them into needing long-term care placement, which is important and regrettable for them, but also for the system. Okay, next slide. Just as another example of some work we've done, and this particular one was funded by the Canadian Frailty Network, we did a survey of about 5,000 older Canadians, and because of the way we did it, it was an internet survey, so we caught the less frail end of the older adult population. So there we have 7.8% being vulnerable, and just less than 2% were actually frail. They were older though, so they were a mean age of 71. And we asked them whether they had gotten the vaccine in that season, what they thought of the importance of influenza as an illness, and how important it was to prevent it. And then we actually, the thing that was the most interesting to me was we asked them questions that would allow us to measure their frailty at the beginning of the season, and then what they were like afterwards, after the season. Also their function in basic activities of daily living and instrumental activities of daily living. And so what we found is that about 21% of them said they'd had influenza, and we worded the questions carefully to try to weed out the ones that were just like a flu or a less severe illness. And of those, 20% of them said that they were not able to do their daily activities during the acute illness, as one would expect, but that means they need help from somebody, or else they rely on public services or end up in hospital. And interestingly, 40% of them said it took longer than the usual sort of 2-week benchmark to recover. And some of them said they never had fully recovered, and this is a few months out. And looking at the risk factors for these declines in function, older age, memory loss, and actually having had the influenza or influenza-like illness were some of the independent predictors. So it just shows us that even in a relatively healthy sample, you do have some people who have persistent difficulties after a bout of the flu. And again, we want to prevent that. As part of this survey, we also asked them about the types of vaccines that they had heard of, and whether they would be willing to pay for a different vaccine if it was more effective, such as, say, the Highdose one that was recommended by the NACI, the immunization recommendations in Canada. And so that's published separately. You may be able to find that on PubMed now. So the third key point is, as we had alluded to earlier, that older adults may not present with classic symptoms of influenza-like illness. And to me, this impacts clinical care, as in like when one is sitting in the emergency department trying to decide how to treat a person who's in front of you. Oh, next slide, sorry. And then it also has implications for surveillance. So on a system level, if we're trying to say this year in Canada, there were 3,000 admissions to hospital from the flu, if we miss more than half of them, then that's going to underestimate the true burden. And it has implications for our decision making as well with regard to vaccine programs. Okay, next slide. So I took this on as a bit of a pet project because of the time that I've spent sitting in the emergency department watching people miss the diagnosis of influenza. As we heard, older people may present atypically with illness from any illness, but in particular here where we're talking about the flu, they may not have the fever, they may not even have a cough. There may be no respiratory symptoms whatsoever. So what I did here was in a pooled data set with several thousand people who had been admitted to our network. I've looked at recreating 2 different definitions of influenza-like illness. So one is the WHO one of ILI, that's the one on the left, where you have to have a measured fever and a cough, and it's come on within the last 10 days. And then there's another one that's a little bit more forgiving for the older population, I thought. It's called SARI, S-A-R-I, and it is an acute respiratory infection with a history of fever or being feverish. So the person can say they felt it, and it doesn't have to have been documented on the chart, and also a cough. It would have come on in the last 10 days. And it requires being in hospital, because when they're looking at SARI, they use it for some of these other outbreaks of different viruses, not just the flu. Certainly all of our people in the network have been hospitalized, so they would all meet that criterion. So looking at the sensitivity, which is what % of people you're going to pick up using this definition of influenza-like illness. Next slide. I just pushed the button there. The sensitivity was only 44%, meaning that you're going to miss more than half of older people in the emergency department, say, if you rely on this type of surveillance definition clinically. If you compare that to, say, a younger person without a high-risk condition, about 57% of them would meet the criterion. So not perfect, but looking a little better. So when you look at the SARI over on the right, if we relax the definition of fever a bit, we do improve things so that the sensitivity is 57% of older adults would be picked up using that definition, compared with over 70% of the people without a high-risk condition. So this is just to say, certainly clinicians need to keep this in mind, but also on a surveillance, from a surveillance perspective, if we want to think about the true burden of the flu, we are going to need to think about how we do our definition. If you don't look for it, you won't find it. Okay, next slide. So just to recap our 3 key points. The first was that frail older adults are at increased risk for the flu and its complications, and vaccine effectiveness is lower. However, with the caveat that if you look at frailty and you stratify or you adjust for frailty, you'll actually find that older adults can benefit quite nicely from the flu vaccine. The second is that the burden of flu we need to think about the longer term consequences with persistent functional declines if we're going to wrap our heads around the true importance of preventing the flu. And the third thing is that older adults will present atypically. So next slide. So this answers our questions around what does frailty have to do with influenza. First of all, we need to understand frailty to define influenza illness and measure the vaccine effectiveness. And we need to understand the impact on frailty and function. Next slide. So, so these figures come from my colleague Jen McElhaney, who many of you will have heard about. She's a fabulous contributor to this field. And so what she's done here is looked at the clinical frailty scale from 1 to 9. So the number 1 is the best on that scale, not frail, and number 9 is extremely frail, end of life. And so as people accumulate health insults, they tend to progress and get more frail. With time, they kind of go down this hill. Hopefully it's not a cliff. Okay, but next slide. But ideally what we'd like to do is prevent this frailty, reverse it, or prevent the disability that's associated. So we have some candidate interventions that can help with frailty reversal, and there are studies coming out on this all the time. So looking at exercise and nutrition, and certainly we can help prevent consequences of iatrogenic frailty, so doing bad things or things that are harmful to people rather than things that help. But if we can avoid illness and hospitalization and prevent illness, we'll also be able to prevent some of that disability. So we're talking here about vaccine preventable disability. So next slide. So how can this impact practice? So we should really be actively recommending vaccination for older adults at all grades of frailty. I emphasize too that even though I talked about how it's the vaccine effectiveness is quite high in the people who are not frail, we certainly recommend it in the frail people as well, because every little bit helps, as we've heard before. We can consider different vaccine products depending on what's available in one setting. And I think we'll hear about that a bit more in the third presentation as well. We need to prevent influenza in the people around these older adults who are very vulnerable. So healthcare workers, family members, very important. And think about the basics with isolation and hand hygiene too. We need to broaden our surveillance and clinical diagnosis criteria, because if we don't look for it, we'll miss it. And then really consider frailty and function. So next slide should be about the last one. So if you put it all together, I'm a big fan of this Swiss cheese model of how things go wrong. So in order for the insults or the bad thing to add up to injury and persistent functional declines in this case, the holes all line up. So first of all, on the far right, you'll see the person who's frail, their holes in their Swiss cheese are big. So we need to protect them with upstream things. We need to be able to diagnose their condition better. We need to avoid exposing them and prevent the illness if we can, with vaccine coverage being better with the existing vaccines, and then developing better vaccines into the future. So with that, I'll say next slide, and thank you for your interest, and I'm certainly happy to take questions probably at the end with the others.
Melissa, thanks very much. It was a terrific presentation and really interesting to get so much information and looking at influenza as it pertains to older adults with frailty and the unique complexities of that population. Yes, we will, I think, go ahead with the next speaker and save the questions until the end. It's my great pleasure to introduce Richard Badek. As we all know, we've had a good discussion about some of the science behind the influenza vaccinations, but let's face it, implementation and getting citizens vaccinated each flu season is a monumental task for a healthcare system and jurisdiction. So on that front, it's really great to have Richard join us today. Just briefly, as you see, he's Manitoba Health's Director of Communicable Disease Control. So influenza is not the only issue in his portfolio, and through his organization, they take a leading role in addressing communicable diseases and vaccinations and promotion across the province. So Richard, I'll keep it brief, but thank you for joining us today. The floor is yours, and a final reminder just to set yourself as the presenter to control your slides.
All right, thanks very much for that. I'm just gonna make sure I have my, there we go. I think is that displaying properly? Looks
good from here.
All right, great. So thanks very much for that introduction and for the opportunity to present today. So basically, in 2017-18, Manitoba was the first province to introduce a high-dose influenza vaccine program for seniors in long-term care as part of the publicly funded immunization program. So I'm going to talk a little bit about that today. I don't have any relationships or conflicts to disclose. And so just going over the talk, I'll talk a little bit about history of influenza vaccine in Manitoba. I'll talk about the essential components of our 2017-18 high-dose influenza vaccine program for residents aged 65 and over in long-term care. I'll take a closer look at a comparison between the 2017-18 and 2014-15 influenza seasons in terms of epidemiology. And that's because we really saw that they were quite similar in terms of the epidemiology, and so that comparison was framing it's our primary comparator in terms of our program evaluation, which is the last element that I'll be talking about. So back in 1999, Manitoba had a targeted seasonal influenza program, and this was based around the high-risk groups identified by NACI, the National Advisory Committee on Immunization, and included seniors 65 years of age and older, as well as long-term care residents. Beginning in 2009, the seasonal influenza vaccine was made available free of charge to all Manitobans. In 2015, we transitioned from a trivalent to a quadrivalent vaccine. So rather than protecting against 3 circulating strains, the vaccine would protect against 4. And last season, we introduced high-dose influenza vaccine for residents of long-term care aged 65 and over. So I already mentioned that the flu vaccine is free of charge for all Manitobans. However, we still do highlight the importance of certain groups receiving vaccine every year, and that's the list that you see on the screen now. And top of the list are people 65 years of age and older, and residents of personal care homes or long-term care facilities. So in terms of our discussion and analysis and evaluation of our around the decision making to introduce an enhanced flu vaccine in Manitoba. It goes back all the way to 2013. So in Manitoba, we have a Provincial Vaccine Advisory Committee, or PVAC, which is a group of experts that we use to engage and help with our decision making and making recommendations around program changes that we'd be making to the publicly funded immunization program. So going back to 2013, there has been discussion and consideration given to introducing a senior-specific influenza vaccine for those 65 and over in long-term care. Then in fall of 2015, Health Canada's Biologics and Genetic Therapies Directorate approved high-dose influenza vaccine for use in Canada. In January of 2016, NACI released a literature review on high-dose influenza vaccine. And following that, we had discussion at our February PVAC meeting, and the recommendation came out for our group to do a formal review and bring it back for a decision or recommendation later that year. So in October of 2016, the PVAC committee did recommend the introduction of a high-dose influenza vaccine program. Around the same time, the 2016-17 NACI statement recommended high-dose influenza vaccine for seniors. And finally, the last component was formal central government approval, which we received in August of 2017. So just briefly, the NACI statement identified that it's expected that high-dose influenza vaccine should provide superior protection compared with the standard dose vaccine to those who are 65 years of age and older, given the burden of influenza A, H3N2 disease, and evidence of better efficacy in this age group. So just to go over in a little bit more detail, the elements that made up our case for high dose. So the first was the NACI statement. Second is the evidence, some of which has been presented today. The Fluzone HD does provide better protection against those strains which are included in the vaccine. Then the highest number of cases, as well as the incidence of influenza A and B in Manitoba, occurs in the senior population. And seniors in long-term care facilities are known to be particularly susceptible to complications, including pneumonia and bronchitis. These lower respiratory tract infections are a leading cause of hospital admission in adults 65 years of age and older, particularly in frail older adults. The last bullet I wanted to just concentrate on a second here, and that's because our decision was around continuing to use a quadrivalent product, standard dose, which would protect against 4 strains, versus moving to the high dose product, which would not provide protection against one of those strains. So that really was a decision point for us. It was the last thing that we considered closely, and kind of the thing that put it over the edge was the expectation that Fluzone HD would provide the superior protection against H3N2 disease. And that's because this strain has historically produced a disproportionate burden of illness in those over 65 years of age. So in terms of implementation, we had to start by determining our target population size. So our ministry has a bed map of the 125 licensed long-term care facilities in the province. And there were just over 9,000 residents eligible for high-dose influenza vaccine based on this bed map. So we initially ordered 9,000 doses. Subsequently, we did need to order an additional 455 doses. So some of the other things that we did were to develop some resources, both for residents and their families, as well as for facility staff and healthcare providers, which provided information around the high-dose vaccine. And in terms of our operational delivery of the program, residents were offered high-dose influenza vaccine based on the province's recommendation, and only if they refused the high dose were they offered the standard dose quadrivalent product. And that was really around some of the questions around logistics, having enough supply of each on hand if residents were offered a choice between the two. as well as the concern around consistent messaging around the pros and cons of each. So this is an example of some of the resources we made available. So this is a question and answer document specifically for healthcare providers, and the intent there is to give them a better understanding of the program and to make it easier for them to answer questions that they receive from residents and family members. And on the other hand, this is a modified version of our influenza vaccine public health fact sheet. This one specifically for long-term care, which included information about the Highdose vaccine. So flu vaccine distribution in Manitoba, we distribute all of the vaccine centrally. And so we prioritize distribution of vaccine to locations that have populations at greatest risk of influenza and its complications, those being hospitals, long-term care facilities, and First Nations communities. All subsequent orders from healthcare providers are processed after those initial priority orders have been shipped. And a little bit of a complication for the 17-18 flu season was that Highdose vaccine was delivered to Manitoba after the initial standard dose vaccine supply arrived. And this created a situation where there were delays in the Highdose vaccine distribution. And just another piece of context, so the total number of doses of flu vaccine shipped between September of 2017 and April of 2018 was about 420,000, and those went to 827 unique provider locations. So there really is a pretty significant logistical component in getting, in supplying each of those locations with enough vaccine to meet their local demand from clients. Getting into specific distribution of high-dose influenza vaccine, healthcare providers who are ordering on behalf of the long-term care facility were asked to complete a special form. Warehouse staff then entered those orders into our inventory system, including information about the facility name and the number of licensed beds. Orders were all reviewed by our inventory management specialists centrally at our department, including cross-reference of the number of beds from the bed map to the number of doses ordered. Once product arrived at the warehouse, the orders were processed and shipped to 112 different locations, along with standard dose vaccine, which was used for staff as well as residents under 65. Later in the season, product was redistributed by regional public health staff in order to minimize wastage of any unused high-dose influenza vaccine. So this just shows the special vaccine order form for long-term care facilities. A couple of points, or there are elements that are specific to our inventory system, like holding point. In the top, there's also information about the long-term care facility, as well as special delivery instructions. And the bottom part of the form just was another way of sort of confirming that orders were being done correctly. So identifying the number of beds, the number of doses for those 65 and older, and the number of doses for staff or those 65 and younger than 65. And that was to ensure it was another check for the person ordering to make sure that they're making their orders appropriately. So Manitoba has had an immunization registry for more than 30 years, and it allows immunizations to be recorded on a client's electronic public health record. And the registry is part of what we call the Public Health Information Management System, or FIMS. And immunizations can be recorded in one of three ways. There can be direct data entry by users who have access to FIMS. That's primarily regional public health staff. So if they're administering the vaccine, they would also enter that data. In some instances, for example, individuals who don't have a personal health identification number, there's a form to complete which can be submitted to public health, and they would enter the data that way. For people who receive their immunization from a pharmacist, there's an interface between the Drug Program Information Network system used by pharmacists and our FIMS. So those will be uploaded regularly. And similarly for physicians, the physician billing system feeds into our registry as well. So those physician-administered doses are uploaded in that way. A few years ago, we introduced this inventory module of FIMS, and this has really increased our department's command and control around all influenza vaccine inventory. And by having our inventory management specialists work directly with healthcare providers to match flu vaccine supply with demand, we were able to realize some pretty considerable efficiencies. And this is actually something that helped in our argument to introduce the product in the first place. So realizing some of those efficiencies allowed us to basically save money in those areas and freeing up some money, additional money for the product itself. Now, I wanted to do a bit of a comparison between 2017-18 and 2014-15. So these are extracts from our weekly influenza reports. On the left, we have the 2017-18 season. On the right, we have 2014-15. And the point to kind of pull out of this is the similarity in terms of the number of lab-confirmed cases, particularly in flu A, similarity in hospitalizations and ICU admissions. There is this is important, the number of flu B cases is higher in 2017-18. And this is just at end of season numbers. So we really see the similarity in flu A. Fairly similar numbers in the severe outcomes. The number of outbreaks is lower in 2017-18 compared to 2014-15 for flu A, but higher for flu B. And we have pretty similar immunization rates at the provincial level. This shows the curve of cases. So the numbers on the bottom are the week number in the calendar year. So number 1 is the first week in January, 52 would be the last week in December. The green line solid line is the 2017-18 season, and the dashed blue line is 2014-15. So looking at flu A, they're very similar in terms of both the number of cases and the timing. And we see for flu B that the 17-18 season was a more significant season than any of the others that I'm showing here. So now I'd like to talk a little bit about our evaluation plan. And so the first thing I'd like to say is that this isn't a formal scientific evaluation of vaccine effectiveness. That's not something that we're really equipped to do right now. So what we did do is a couple of different elements. One is qualitative. So we had a survey that went out to long-term care facilities. I'm going to get into that in some detail. Then some quantitative data. So laboratory confirmed cases in long-term care by season and age, vaccine safety, vaccine coverage by season. Looking at respiratory outbreaks in long-term care. So all respiratory versus those caused by influenza, attack rates in long-term care, and then in some cases some more detail we're hoping to get to. So I don't have all of this data today, but I will be doing a little bit of the descriptive data, and we expect that more will be available later. So things like hospitalization, specifically among those immunized in long-term care. That type of data is not as easily accessible or as immediately accessible, but we expect to be able to get into some of that type of analysis early next year, is our hope. So our survey, we did distribute a questionnaire through SurveyMonkey to all long-term care facilities within the province to get feedback on the launch of the program. So we sent it to 125 facilities, and we had a 53% response rate, which we thought was quite incredible, actually. It was higher than what we would normally see. The pie chart shows the distribution among all regional health authorities in the province, and so we are getting, so the lowest response rate in a particular RHA was 33% of facilities in that RHA. So we are getting good representation from each region. So we looked at which facilities offered high-dose influenza vaccine. And so there was one facility that responded saying they did not offer the vaccine, and they advised that they opted to offer the standard dose influenza vaccine instead. The next question was about acceptability of high-dose influenza vaccine by the residents. And so whenever I'm showing something with a scale, 5 is the best possible answer, 1 is the worst. We can see that 68% answered 5 in terms of acceptability, and the lowest answer received was 3. We asked about safety concerns from the staff and/or residents and family. 85% identified that there were no concerns. Among the 15% who did identify concerns, they talked about the potential additional side effects, concerns about additional benefits or efficacy of the new vaccine compared to standard dose, and concerns with being guinea pigs. Staff were reportedly able to address the concerns raised using the resources that we provided. The next question was about the usefulness of the resources created by the department. So again, on that same scale of 1 to 5, the average score was a 4.3 from staff and 4.22 for residents. There were a few suggestions, such as the brochure, which compared the available vaccines using more concise and simpler language, using larger font, and earlier availability of the information and resources. We asked about the accessibility of the vaccine from the warehouse, and 90% identified no issues. There were some suggestions, again, like a clear description of product format, arrival with other flu vaccines to the facility, and again, that was the issue around the delay in delivery to the province. And as also ordering based on the consents received from residents rather than on the long-term care facility population count in order to reduce wastage. We asked whether the facility would like to see high-dose influenza offered in the future, and 91% said that they would. Some of the feedback there was that although there were still outbreaks, the illness was not as severe. Among the 9% who said no, they identified increased confusion with multiple products, unsure about the increased effectiveness and the corresponding increased cost, and some identified that regular vaccine and hand washing is sufficient. In conclusion, we found that the program was well received in long-term care facilities in Manitoba. The majority of residents accepted the vaccine, and the resources developed were useful for staff, residents, and their families. Manually recorded facility uptake of high-dose influenza appeared to be consistent with previous year's uptake, and since then I can confirm that based on registry data. Concerns around potential of additional adverse events were minimized through education, and the majority of long-term care facilities that responded reported that offering the high-dose vaccine to residents should continue for future seasons. There were some recommendations. So one was earlier communication of the program plan. Again, that's something that we typically would be doing. The complication in this instance was that we only received final approval to move forward in August. The second is development of a brochure comparing flu vaccines. And while we haven't been able to do that specifically for this season, we did update our seasonal influenza vaccine for residents of long-term care facilities with some of the same information. So comparing the high dose to the standard dose vaccine. A recommendation around more direct communication with long-term care facilities. So that's something that we're targeting to do. Another one is actually a healthcare provider fact sheet. And so flu vaccine uptake among healthcare workers is low relative to national targets and based on some of the responses we received in the survey. And there appears to be some misinformation and inaccuracies about the use of flu vaccine among healthcare workers. And we are looking at that suggestion in terms of developing a fact sheet directed to healthcare workers on the importance of being immunized, how vaccines work at protecting themselves and those around them, as well as addressing some of the myths. Next, around ordering high-dose influenza vaccine. So we have taken some steps to clarify that ordering should be based on anticipated uptake, not the number of beds in the facility. So that was just a bit of confusion. Now, I can provide a little bit of descriptive data. I don't have a lot to show today. And so this is showing the last 4 influenza seasons. And what we have is reported respiratory outbreaks in long-term care facilities. The light gray part of the bar indicates influenza outbreaks, and the dark gray is other respiratory outbreaks. So although the total number of respiratory outbreaks was greater in 17-18 compared to 14-15, the number of influenza outbreaks was lower. Just a comment on the 4 seasons. So 14-15, 16-17, and 17-18 were all predominantly H3N2 seasons. 15-16 was predominantly H1N1. The other comment on 16-17 is, although it was a fairly significant season in many places, in Manitoba it was really a low impact season. And so those are kind of the pieces that go into our focus on 14-15 as a comparator. Now, looking specifically at influenza A outbreaks, and I'll remind you that H3N2 was really the specific strain that we were most interested in protecting against. We do see that there's a fairly large difference in the number of influenza A outbreaks in long-term care in 17-18 compared to 14-15. And finally, this is just the number of all-cause deaths in those aged 65 and over in long-term care. And we did see 62 fewer deaths in 17-18 compared to 14-15. The last element of our evaluation that I can talk about today is that we did not identify any safety signal detected through our passive surveillance system. Again, I mentioned earlier that we expect to have some more detailed data available beginning early next year, and we will be able to present a little bit more data as well at the Canadian Immunization Conference in December. And with that, I'll leave it for questions.
Great, Richard. Thanks so much. That was a really, really rich presentation on a case study of what the various authorities go through in addressing immunization and vaccination. So really, really enjoyed that. As you might notice, we've come to pretty much our end of our time right now. But as you'll see, we've put up a contact info for the presenters. I've had a couple of quick questions about to Richard about perhaps trying to arrange to make the fact sheets available to share and some of the information that you're using in Manitoba. And folks have asked about the information on the webinar. It will be posted to our website, cfn-nce.ca. So you'll be able to tune in and get all of this information after the fact. So I just want to quickly remind people to take the post-webinar survey. It'll pop up on your screen after the webinar. It's really important information for us in developing these sessions. I want to thank our presenters again, Melissa, Richard, and Stefan. Really, really great presentations. And I want to thank everyone who tuned in today. And special thanks again to our presenting partner, Sanofi Pasteur. And special thanks, of course, to our funder, the Government of Canada's Networks of Centres of Excellence program, for their investment in improving care for older Canadians. Hope to hear from you again at our next webinar on November 7th. Thanks again for tuning in today, and have a great afternoon.